Good afternoon. My name is Dr. Alison Milne, and I'm Professor of Social Gerontology and Social Work at the University of Kent. I'm delighted to be here, albeit virtually. Thank you very much indeed, Irene, for asking me to speak at the Decade of Healthy Ageing Integrated Care Conference today on the 12th of May. I'm tasked with talking about family carers and to what extent are they members of the integrated care team. But just to give you some sense of my expertise, I've been working in the field of caring and carers for many, many years now, particularly in older carers, dementia carers, carers of people in care homes, practice with carers, mainly around social work, but more broadly as well, policy and caring, and have been part of a number of advisory groups and bodies in relationship to family carers and the people that they look after. And passionate about caring, actually. It's one of the areas that I feel really very strongly about, that we need to do much more about in terms of support, recognition, and conceptual activities, which is one of the key issues I'm going to be covering today. I'm a qualified and registered social worker and have been working at the University of Kent for 25 plus years in a range of research projects. So what I'm going to be talking about today are four things. What is the relationship between policymakers and carers? How do practitioners conceptualise family carers? COVID-19 and its impact on carers, and integrated care and carers. What can practitioners do to support family carers in the umbrella, under the umbrella of integrated care? When I refer to carers, I'm mainly talking about carers of older people. That is obviously in part because we're talking about older people today, the healthy ageing agenda, but also because that is mainly where I've done my work. And they are the majority of carers, of course, too. But it is instructive to remind ourselves that there are growing numbers of carers looking after and supporting adults of working age. In fact, in the UK, over half of local authority, i.e. publicly funded care for carers, is now, for people of working age, is now spent on that group. So not older people. So the majority of people who receive publicly funded care in the UK are now adults of working age, not older people. It is also useful to remind ourselves that a growing proportion of the total number of carers are older people themselves. It's at least a third, we think, in the UK. Now, I would argue that policy and policymakers have an ambivalent relationship with family carers. On the one hand, we need carers to continue caring, but we also acknowledge a duty to protect carers from harm, preventable ill health, leaving paid work prematurely and often when perhaps you're at the peak of your game, middle-aged daughters perhaps, for example, and of course of falling into poverty almost certainly permanently. The benefits of family care are strongly promoted in policy discourse. There's a heavy emphasis, often a very positive emphasis, on keeping an older person at home where, quote, they are naturally best placed and belong. There are more explicit policy tensions too. Those are perhaps a little bit more opaque, a little bit more hidden, between the aims to promote community-based living for all adults with dependency needs, to promote choice, control, self-directed care, and so on, and ensure at the same time that family carers can live a life outside caring and be supported to care. And that's certainly explicit in the UK 2014 UK Care Act. There's also a tension between the political imperative to exert strict controls over public expenditure, and I'll come on to that a bit later, which can find itself at odds with the imperative of satisfying high levels of public expectation that people with support needs and their carers will receive that support and be enabled to care safely in the community. There's also a tension between free NHS care at the point of access and means-tested social care services. And this is a long-running issue in the UK, and I suspect in Ireland as well. Carers historically and in policy terms kind of belong to the social care arena, and that is fraught with all sorts of issues around costs, access, and so on. Again, I'll come on to the access and costs issue in a moment. I just want to highlight what I would call some sort of fishy issues in relationship to terminology. Terminology is everything in the carers arena, I would argue. And it's important for us to unpack policy documents because they are vehicles of normative paradigms. In other words, they represent what policymakers, what wider society regards as important, as significant. And terminology, as I've just said, is important in this regard because it represents public and policy perceptions. In policy, carers are inevitably conceptualized as heroic and competent, as people who know what they're doing. And caring is woven around rosy, positive concepts of love, duty, obligation, mutuality, reciprocity, and attachment. By the way, I'm not arguing it's not that, but it's not just that. And policy certainly foregrounds the positivity of family caring, both for the carer and the person they're looking after. The care relationship in most documents, including quite a lot of literature around caring itself, is presented as positive and benign, rather than complex and nuanced and demanding or even damaging. They're unpopular discourses, the more negative discourses. And caring is often constructed relatively simply or straightforwardly, if you like, as a set of instrumental tasks: physical care, getting someone out of bed, getting someone dressed, helping someone feed, helping someone bathe, go to the toilet. That is how most care is presented, as physical or instrumental care. It's not about the emotional nature of caring, the journey of caregiving, the relationship, the care relationship itself is not a nuanced, emotional, lived experience. So policy, I would argue, masks that, sidelines it, marginalizes it, may not even want to think about it because it's a little bit more messy, a bit tricky, a bit more opaque. Now, there are some additional newer tensions relating to austerity. For at least a decade in the UK, we've had some savage cuts to local authority budgets. And those are the budgets, by the way, that support social care services, including services for carers. And the cuts really constitute what I would call a double whammy for carers, in the sense that cuts to services for the person they're looking after have been accompanied by cuts to services for the carers themselves. Austerity measures, so-called, have resulted in much tighter access to publicly funded services and very high eligibility criteria, or access to publicly funded care. This has inevitably placed additional pressures on carers. The care needs of the people they're looking after haven't gone anywhere, but if the state is withdrawing its support or making it very, very challenging to access that support, then who's going to pick up the care tab? The answer is family carers. So they have been doing more care for longer, more intensive care, and offer more complex care. I'll come back to that in a moment. That is accompanied by the fact that there are far more people now living in the community who may have gone into a care home 25, 30 years ago. People with very complex comorbid health conditions who are being supported at home by family carers, who are doing more complex care tasks, quasi-medical care tasks in some cases, and they're more demanding. What we do know is that despite these additional demands, carers themselves are receiving very low levels of support. We think that only about 10% of carers receive an assessment of need. And please note, this is actually a statutory duty under the Care Act for those people who are carers who ask for an assessment of need to have one, and to have any eligible needs also met by that local authority. And we know that the number of carers in receipt of publicly funded care is falling. I just mentioned that in relationship to both the person they're looking after and themselves. And this is a reduction that's been amplified by COVID. I'll come back to that. And Manthorpe and Iliffe suggest that there is a cruel, rather dark side to the increased expectations placed on carers, that the effects of poorly resourced care become framed as a moral failure on the part of family carers, who may be accused of being abusive or neglectful of the person they care for. In other words, perhaps the responsibility for the carer collapsing or falling asleep at the wheel, or perhaps giving the person they're looking after an extra sleeping tablet when they really shouldn't be doing that because they're completely exhausted. Maybe responsibility for those actions should fall at the feet of service providers and not at the feet of carers. And remember, quite a lot of these carers are elderly, frail people themselves. Moving on now to think more specifically about how carers are conceptualised by services and professionals, I want to begin by going back a number of years to the 1990s, where Twigg and Atkin did some seminal work looking at how professionals, mainly social care workers and social workers, working with families and those with care and support needs, what models did they adopt? What lens did they adopt in thinking about conceptualising carers? And they developed a model. They said there were, sort of broadly speaking, there were 4 groups. There were carers as resources, where the aim of an intervention is to support the carer to continue caring. Carers as co-workers, the service complements the carer's role. Carers as co-clients or co-users, carers have a right to a service in their own right, and services relieve them and enhance their well-being. And what they called superseded carers, services support the service user to the extent the carer's input is no longer needed. I can almost hear you laughing hollowly, even though I'm not there. That rarely happens, of course. More recently, carers as experts has also perhaps joined this model or been an additional conceptual lens through which we view and understand carers, and one that resonates both with the neoliberal notion of the care consumer and the principles of citizenship. But it is notable that this concept of expert is having expertise in the care needs of the patient or the user, not on the experience of being a carer, nor user in own right or lived experience. I think the point I want to make here as well is that support for carers and our understanding of carers don't exist in a vacuum. They exist inside a socio-political context, which policy reflects. Now, there is evidence from research more recent than the 1990s. In 2003, Manthorpe and colleagues did a study of primary care staff's view of carers of people living with dementia, and they identified a clear conceptualisation of carers as co-workers. In particular, carers were, if you like, responsible, had a key role regarding medication management, supervising the taking of medication, monitoring the side effects, and helping with patient compliance, and would feed back to the community nurse who visited about that. And carers also alerted professionals, primary care professionals, to changes in the person living with dementia, their mood, their behaviour, their health. So another a kind of broad monitoring role, if you like. So they were almost co-workers as far as the primary care professionals were concerned. More recent research suggests that carers feel they are regarded and treated by professionals as free resources, and that the primary function of services is definitely to keep them doing caring, mainly the physical care, the instrumental care tasks I referred to earlier, almost regardless of how they are managing. This perspective or conceptual frame is reinforced by additional evidence that carers are routinely excluded from decisions about their relative's care package. Carers' input is taken account of before services are allocated. And services, in other words, are a substitute for the carer, not an adjunct or a complement. My next question relates to, are we in fact shifting the lens even further towards carers being unpaid members of the care workforce? We're beginning to offer carers training to do increasingly complex tasks, lifting the handling, monitoring medication. I mentioned that already. This, I think, is emblematic of the stealthily growing role of carers in care provision. Are we perhaps explicitly recruiting carers into the workforce? Are we transferring risk and responsibility for arranging and providing care from professional paid staff to carers. There is evidence that this transfer or this shift is placing new emotional demands, as well as obviously additional physical demands, which I've discussed already. Clark et al. Refer to this as the devolution of stress, and others would argue it's a devolution of risk as well. Managing complex care tasks and making key decisions is often challenging and emotional. Should you think about your husband being moved into a care home? How might you consider ordering incontinence pads? Should you think about daycare? When your husband's in hospital, how are you going to manage that hospital discharge? These are questions that in part are still managed by services and professionals, but used to almost totally be managed by professionals, and now are being managed increasingly by the carer alone, or with very little help from professionals, with a list of resources to go home with. And these issues are having an impact on the health well-being of carers. Obviously, it creates increased stress and anxiety, and it's particularly pronounced for older carers who struggle to navigate the complex system. It's very complex in the UK. It's bad enough when you're trying to understand it as a professional, but it's very, very challenging for an elderly carer who may themselves, as I said earlier, have their own health issues. And as professionals, should we be doing this? Is it right? Is it safe? Does it take account of the carer's age, health, and wishes? And are there safeguarding issues? And by that I mean, are we placing the carer themselves at risk of harm? And are there any limitations to the caring role? Are carers going to simply be doing everything sooner or later, and professionals doing almost nothing? And I've got a quote here from some work by Milligan, which I think illustrates the point very well. The nurse said, "You will need to give him his drugs," which was strong opioids, "when I'm not here. I'll show you what to do. You will have to be me when I am no longer here." So that's a clear message to this carer. The nurse is saying, you're going to be the nurse, you're going to do the nursing job when I'm no longer here. And I think there's a number of things that are missing from current practice. And this conceptual frame takes us down a certain rather narrow residual path, is what I'm arguing. One of the challenges of policy is that it assumes rather unproblematically that people will simply identify as carers. There's a lot of emphasis on identifying and recognising carers, but it ignores the fact that many carers do not recognise themselves as carers, or indeed that they're adopting a role of carer. Well, for a start, most carers don't become carers overnight, road traffic accidents and strokes notwithstanding. For example, if you're looking after somebody with dementia, you're not a carer on a Sunday and suddenly a carer on a Monday. Usually happens gradually. Relatives are often very concerned too, that to adopt the identity of carer will mean that they lose the identity they may have had for many, many years as a partner, as a parent, as a daughter. And they wish to protect their identity as the husband or the wife or the parent. They also often wish to protect the cared for person. As soon as you talk about being a carer, what are you doing to the relative, to the person that you love? You may have been married to this person for 40 years. You're kind of positioning them in a burdensome role, in a needy role. And a lot of people are just not willing to do that and will almost resist the idea that they're a carer to protect themselves and the person they're looking after. And care is an intrinsic dimension of a family relationship, often of long standing. It's embedded in that relationship. It reflects the things I mentioned earlier: mutuality, love, obligation, care. So being a carer is an extension for many carers of that relationship. It is not a set of activities. It is that, by the way, it is doing care, but being a carer is much more than doing care. It is often both. Practice models tend to ignore the relational nature of care. And don't forget, this is often a long-term relationship we're talking about, marriage, parents, and so on. Support is not focused on the relationship or dyad, but on the separate patient or carer, and ignores the dyadic shared life course, the mutuality often that characterises care relationships. So this not only fails to reflect the reality for most carers and cared for people, but it also ignores the fact that co-caring often occurs, mutual caring. For example, there are many elderly couples where one member of the couple may have dementia and the other may be frail, and they rub along okay, they complement one another. One is, in essence, caring for the other, they're co-caring. So the carer-user construct doesn't really fit. Well, it doesn't fit most care relationships, actually, but it certainly doesn't fit where there is mutual caring going on. The other thing that I think practice misses is that most couples, most dyads, I'm talking mainly about spouse couples here, but it could also be a parent with a son or daughter with disabilities who perhaps they've lived with for many, many years, or indeed a son or a daughter looking after an elderly parent. Most dyads wish to remain independent as a unit and want support to promote the well-being of the unit, recognizing its interdependency and reciprocity. So it's not about your independence, it's about the independence of the dyadic unit. And again, practice models tend to struggle with that. And there's a quote here from a piece of work in 2016 from an older person saying, it was only when we made contact with the carers centre and we explained a few things that the assistant manager said, you were all carers, by the way. Up to that point, these people hadn't seen themselves or viewed themselves as carers. Many people just see themselves as a husband or wife doing caring as part of their normal role. So if we expect carers to identify themselves, we're in trouble, aren't we, for the people who simply are never going to adopt that label. They are doing caring and need support often, but we've got to be careful about the language we use. Now, I want to move on to COVID, my third issue. We all know that COVID swelled the ranks of carers dramatically. Since the pandemic began in early 2020, the percentage of carers has risen in the UK dramatically from 15% to 26% of the adult population. This means that up to 13.6 million people, 1 in 4 adults, are providing unpaid care in the UK currently. The percentages of carers across each of Wales, Northern Ireland and Scotland is on this slide. I'm sorry, I don't have the figures for Ireland. The other thing to note, which I've already mentioned, is that, and this was amplified in COVID, has been amplified in COVID, is that more carers, of course, not only were there more carers were also doing more. So there were new carers, but the carers already there were also doing more, in part because the support services that they may have been using for many years, day services, respite care, support for themselves, carer services and so on, were mainly closed. Home care was radically diminished, and there were far fewer visits from community nurses, social workers and other support workers. And of course, family and friends couldn't visit either to provide relief or just emotional support. I want to move now to looking at some of the impacts of COVID on care homes. I've written elsewhere with colleagues, and et al., it's in the references at the end, about the human rights issues in care homes. And this is an issue about which I feel extremely strongly. I think care home populations, residents and families and staff really were treated incredibly badly. In the UK in particular, they were really abused and their human rights were completely contravened during the COVID pandemic. One of the things, I'm only going to talk here about the visitors and the families issues, but if you want to read more about how I think the human rights were contravened for all groups, please do read the Anand et al. Paper in the European Journal of Social Work. And one of the ways in which risk reduction was managed in relationship to care homes was a ban or severe restriction on visits by relatives to care homes during at least the first phase of the COVID pandemic. And residents were also effectively trapped in their rooms, isolated in their rooms. And we know that visitor exclusion, particularly relatives, often carers, had a profoundly detrimental effect on residents' mental health. And Irene Hartigan, and who you know well, and colleagues identified this in Ireland and elsewhere. Many experienced residents high levels of distress, depression, anxiety, isolation and loneliness. And for residents with dementia, the lack of contact and social engagement had really very profound, irreversible effects on cognitive function. There's quite a lot of evidence about that now. People deteriorated cognitively, and of course also behavioural symptoms. And there was an increase in the use of antipsychotic and hypnotic medications during this time. And Hartigan again et al. And others have said that whilst the banning of visitors and isolating of residents could be viewed as a relatively kind of quick win, easy, common sense response, if you like, to managing the pandemic, it failed to recognise the significance of resident-family relationships in enhancing residents' mental health, cognitive health in relationship to dementia, and the quality of their lives and care. Because, you know, relatives do a lot in relationship to care. When they're described as visitors, that massively underestimates the role they perform, which is quite complex, it's nuanced. You know, families do a lot of things in relationship to residents in care homes, as I'm sure most of you know. So even the construct of them as visitors is an issue, perhaps of itself. COVID highlighted a number of structural issues too. It shone an uncomfortable light on the care home sector, and the vulnerability of residents was made much more visible, as was their disempowered status and that of carers too. Residents have limited freedoms, agency and choice. They were obliged to stay in their rooms when told to by the government. I think also it reminded us that they are institutions. In how many homes are you locked in your room or need to have permission from an external agent to receive a visitor? It was a setting in the UK, at least, that was required to admit untested hospital patients, which had massive damaging consequences for the spread of COVID in care homes when told to by the UK government. The Department of Health Ireland noted that given the power asymmetries in long-term care facilities between residents and their families and health and social care workers and managers, care must be taken not to impose disproportionate or coercive measures to achieve the ends of safety, efficiency, or other organisational goals such as risk reduction. The British government is not capable of any such reflection, but it has been successfully sued for preventable deaths of care home residents by 2 family carers, and the High Court concluded that the government acted unlawfully by discharging untested hospital patients into care homes during the early stages of COVID. No one as yet, as far as I can tell, has been held accountable for this. Just a couple more slides on integrated care. Where does the carer fit in? Well, in the UK Department of Health documentation, we interpret the concept of integrated care as giving people the support they need, joined up across local councils, the NHS and other partners. And the point is it removes divisions between the various elements of someone's care and support package between the NHS and social care and other divisions. In Ireland's National Carer Strategy, I was very interested to note that your interpretation, if you like, of integration is between family and formal carers. So there are 2 axes, if you like, formal services and family and formal care. I was struck by this. To support family carers through integration of formal services for care recipients and to involve them in formal care systems. And the vision of this carer strategy is to recognise and respect family carers as key partners and to support them to maintain their own health and well-being with confidence. Your evidence suggests there is an implementation gap or deficit, i.e. between the aims and the delivery. There always is, isn't there? But via Family Carers Ireland's independent monitoring group, there is some evidence of greater levels of engagement with carers by the Irish government about available support and a number of other issues. For example, extension of welfare support post a patient's death, welfare benefits support post patient's death or admission to a care home. One of the UK aims of integrated care system is to offer joined up and person-centred care to users and their families. But in policy guidance, there is almost no mention of family carers or indeed of local authorities, apart from as partners with health care. It's very health care dominated. I'm very concerned that carers will be treated even more as a free, even exploited resource in the new integrated care framework in the UK. Just 2 more slides now. I know I'm going a little bit over time. The whole care system relies on family carers. I think we have to acknowledge that. They need to be protected, respected, supported. They deserve empathy and to be treated as partners, but not unpaid members of the workforce. I am very concerned and quite angry about a shifting of discourse, a shifting of terminology. Is it morally defensible that carers are doing quasi-medical tasks? I asked about this earlier. Is this level of responsibility right ethically, even legally? The carer population is aging, carers are caring for longer, doing more complex tasks. It's the job of practitioners to appreciate the impact of these demands on carers and offer them space to decide not to care, not to do these ever more burdensome tasks. Some carers are abused by the person they support. That person may not intend to abuse them, but we know that it happens. This needs to be addressed with kindness and as a safeguarding issue. Carers are patients too, and are people beyond being a carer. So interactions with carers need to recognise that individual separately from being a carer. Again, they're not just part of the workforce. In terms of opportunities, I think community nurses, both in the community and nurses in care homes, have a number of opportunities. There is a strong policy commitment in Ireland, not so much in the UK, I would say, to support carers, strong third sector voice for carers too, and they're embedded in policy and related guidance. And there is an example here, if you follow that link, to a Canadian model of how to integrate carers into guidance in relationship to hospitals, but it could equally be applied to care homes. I think practitioners are in a unique situation, really. They have the ear of the carer, unique opportunity to engage with the carer's perspective and the dyadic perspective too. Hear honestly about the ambiguities that characterise caring, the tensions and negative emotions, anger, fear, resentment, and also about the carer's own needs and wishes, with an empathic ear and an understanding ear. Recognising the pressures carers are under, acknowledge carers' complex, nuanced activity, and that it can be harmful to a carer's health and well-being, whether they acknowledge that or not. Sometimes carers need to be helped to see that continuing to care may not be in theirs or the cared for person's best interests. Being aware of support locally for carers, talk a lot about the value of being supported by a local carers organisation, even if it's online or over the phone. Really found it very helpful. And sometimes care homes themselves run carers groups, or third sector carers organisations will run groups for carers whose relative is living in a care home. Engage with carers' concerns and talk about their health and other, for example, worries about money concerns, and advocate for the carer and for carers as a group. Hartigan et al. Talk about ethical practice, ethical nursing practice, and highlight the importance of taking account of 4 ethical principles in ethical decision making relating to care home residents and their families: the right of autonomy, trust, minimising harm, and proportionality. And I just want to end by saying that, in summary, I do not think that carers are part of the workforce, and I think it is dangerous for us to conceptualise carers as part of the integrated workforce. Partners, yes, but separate from the person they're looking after. They are separate individuals who have rights to be heard, to be protected, and to be supported, and to be listened to, and to be offered choices, including the choice to not care. And I think it is part of our role as practitioners to ensure that we take full account of some of the seductive terminology and some of the policy direction that we're travelling in is increasing the risks and responsibilities on carers. And I would urge us all to challenge some of that terminology and challenge some of that thinking in order to advocate for carers and to protect them from some of the inevitable harms that long-term and intensive caring can do, whilst ensuring that if a carer wishes to continue caring, they can do so safely. Thank you very much indeed for your time. As I say, any questions, feel free to ask. Thank you.